slides.
For asking me here today, and it's a pleasure to speak with you. And I'd just like to summarize my talk before I start, and that's that lymph node number is associated with survival in colorectal cancer. But what I'd like you to take away from this is that this is an association. An association does not mean that it is causative, so it's not causation, and that understanding the difference between association and causation is important in terms of quality improvement. And this is VISTA, and I don't understand why my slides are doing this, but anyway. So just to talk a little bit about what I'm going to talk about. First, I'm going to go over the importance of staging, and then talk about the data that we have showing that lymph node number is associated with survival, and then talking a bit about what the difference is between association and causation. I'm going to talk about lymph node number as a quality marker, and whose quality are we really measuring when we talk about lymph node number. This is unbelievable. And then finally to talk about whether improvement in quality based on lymph node counts will actually result in patient outcomes, improved patient outcomes. Well, as we all know, staging in colorectal cancer is important, and lymph node positivity is the most powerful prognostic factor in colon cancer other than the presence of metastatic disease. Basically, we decide on the use of adjuvant therapy based on node positivity, and it enables us to be able to communicate prognosis to our patients. So if we're not adequately staging our patients, it will have a negative impact on patient care. And lymph node evaluation in the past has been inadequate. And this is some research that I did, population-based research using SEER, which has registries throughout the United States, looking at lymph node evaluation from 1988 to 2001. And this included over 100,000 patients surgically treated with colorectal cancer. And about 11% either had no nodes recovered or the nodal harvest was not stated. Overall, the median node recovery was 9 nodes in this population-based series, and only 37% had 12 or more nodes recovered, the quoted standard. But importantly, as you can see, a large number of people had very few lymph nodes evaluated, so 6 or fewer lymph nodes evaluated. So I think clearly there's room for improvement. Just to talk briefly about laparoscopic surgery and node count, and I'll only speak about this briefly because it doesn't seem to actually make a difference in terms of whether you have a laparoscopic or open approach. There have been 7 randomized controlled trials in this area, including over 4,000 colon cancer patients, and no difference in median number of nodes has been seen between the laparoscopic and open groups. So this is not a laparoscopic issue. But it is an issue, and it's an issue because a number of research studies, a large number of research studies have shown that node number, negative node number, is associated with survival in colon cancer and colorectal cancer. These are either can be small single institution studies with relatively small numbers of people to large series to randomized trials. Studies as small as 200 people are able to show an effective node number and survival in stage 2 colon cancer, and a systematic review recently published of 17 such studies shows that in the vast majority of these studies there's a relationship. That patients who have fewer lymph nodes evaluated have a worse survival than those with many lymph nodes evaluated in stage 2 colon cancer. And this is a representative Kaplan-Meier graph from one of these studies. These are patients who have a very low lymph node count. These are patients with a high lymph node count. Huge difference in survival, so much larger difference than you get with application of adjuvant therapy. And this seems to be significant in all stages of colorectal cancer. So stage 1, stage 2, stage 3 all show a difference. When more lymph nodes are evaluated, there's improved survival. And this has led to the concept of the lymph node ratio in stage 3 disease, where it's not just important how many positive lymph nodes you get, but also important how many, what the total number of negative, the ratio of positive to negative lymph nodes is. So it seems to be important with all stages. And it leads one to question exactly what it is about lymph node count that's important. We certainly know that there are quality issues in terms of lymph node count, that it's a function of both how many lymph nodes are taken out by the surgeon and how many lymph nodes are evaluated by the pathologist. And this all influences lymph node count. So doing an adequate mesenteric excision from a surgeon perspective, doing an adequate evaluation of the specimen from a pathologist perspective, these things are going to influence the number of nodes found. But what neither of these things influence is the number of nodes present. And we know that that varies between individuals. We know that there are patient factors that can affect the number of nodes present, things like age. We also know that there are tumor factors that can influence the number of nodes present. Things like depth of invasion. So T stage influences node number, not just node positive count, but also the number of negative lymph nodes evaluated. Things like location and grade. And there almost certainly are interactions between the tumor and the patient-host interaction, that influences the number of nodes present. So a more immunogenetic and immune-stimulating tumor will end up leading to the development of more lymph nodes from germinal centers, and also develop larger lymph nodes so they're easier to identify. And if there are more nodes present, more nodes are going to be found. So one of the main questions quality improvement individuals have is, can we improve staging with better lymph node evaluation? What I think is a better question is, can we improve outcome with better lymph node evaluation? I think those are two different issues. And I think also underlying all of this is, what is the actual true mechanism underlying the relationship between node number and survival? Because that's going to decide, what the mechanism is going to decide what we actually target for quality improvement strategies. And I think it's really important here to talk about the difference between association and causation. So we know that number of nodes are associated with survival. So a lot of people say that means increasing node count will result in improved survival. But let me take you back to Epi 101. So just because something's associated with an outcome doesn't mean it results in the outcome. There may be something underlying both. So there may be something underlying node count that's also associated with survival. And just to give an example, if you did any epidemiologic study, you'd find that having an ashtray in your house is associated with the risk of lung cancer. But getting rid of ashtrays doesn't prevent lung cancer. So even though the number of lymph nodes is associated with survival from colon cancer, it doesn't mean that improving the number of lymph nodes will result in improved outcome from colon cancer. Well, one of the arguments is, if we find more nodes, we're going to have less understaging. So we're going to find every single individual who's node positive if we find as many nodes as we can. And that's going to improve outcome. Well, that's termed stage migration. So you more perfectly characterize individuals with respect to their stage, perhaps, if you find more nodes. So that one individual who would have been categorized as stage 2 if you found 12 nodes, if you find 32 nodes, you're going to categorize that individual as stage 3. So that's stage migration, and it's also termed the Will Rogers effect, because Will Rogers described this phenomenon when he was talking about migrations during the Great Depression. And he colorfully said, when the Okies moved to California, they raised the IQ of both states. Now, no one got any smarter by moving to California. So this is an apparent benefit. So with better staging, there's better stage-specific survival. So you take that person who had 1 node out of 32 out of the stage 2 pool, stage 2 survival improves. Stage 3 survival also improves, because that person with 1 node out of 32 is going to have a better prognosis than the person who had 10 nodes out of 12. So you have better staging. With better staging, you have better stage-specific survival. But there's no effect for an individual patient. Just because you found 32 nodes and one of them was positive in that one patient doesn't change that individual's actual outcome. And it doesn't change the outcome overall either. It's exactly the same. Well, maybe it's a benefit of chemotherapy. So maybe for that one person who you've upstaged to stage 3, you're going to give them chemotherapy and you're going to improve their outcome. So maybe that explains the survival benefit of finding more nodes. Well, just to do a bit of a thought experiment, if we assume that 10% of our stage 2 patients would be upstaged with an increased node count, that would generously be 5% of all patients. That's an overestimate. So 5% of patients would be upstaged. And if we assume that we can improve their survival from 40% to 60% with adjuvant therapy, and that everyone would accept adjuvant therapy that was upstaged, then what we get is that in 100 patients with colon cancer, 1 patient would benefit due to improved staging and delivery of adjuvant chemotherapy, and that's a gross overestimate. And as you can see, there's no way that explains these huge differences in survival seen with increasing node count. So this isn't a benefit of chemotherapy. That's not to say that That's not to say that understaging doesn't occur and isn't a problem. This is a study from the Netherlands which looks at patients who had very few lymph nodes identified, so 0 to 5, compared to patients who had greater than 16 lymph nodes identified. And what you can see is that the rate of node positivity does increase in patients who have higher numbers of lymph nodes identified. Most importantly, it really increases from 0 to 5 to higher numbers. So if you only have less than 5 lymph nodes identified, you're much less likely to be found to be node positive than in individuals who have higher numbers of nodes identified. But it's not quite so simple because it doesn't seem to hold up in a hospital basis. This is some SEER Medicare work that was done, and what they did, which is interesting, they divided hospitals up into quartiles based on the number of lymph nodes identified. So you had hospitals that didn't identify many lymph nodes on average to hospitals that identified a fairly large number of lymph nodes on average. And what they did was they looked at the rate of node positivity for these. Can I go back? Is there a, yeah, back one more? Yeah. So they looked at the rate of node positivity based on the quartile that the individual was in. And what they found was that it didn't make much difference. If you were in the lowest quartile, so your hospital found less than 6 nodes, you had a rate of node positivity for patients in your hospital of 30%. And if you're in a hospital that found a median of 14 nodes, your rate of node positivity was 32%. So understaging may be overrated. And most importantly from this study, what they found was if you were in a hospital that had a low number of nodes identified, your hospital did just as well as the hospitals with a large number of lymph nodes identified. There didn't seem to be a difference in terms of survival. Well, maybe it's surgery. Maybe surgeons do a better job, they get more lymph nodes, patients do better. But it's important to know we actually have some randomized trials of more extensive lymphadenectomy in colorectal cancer, and there's been no trial that's shown more extensive lymphadenectomy actually had a benefit. And that's probably because, when you think about it, isolated mesenteric recurrence as the cause of death for an individual with colon cancer is exceedingly rare. Isolated mesenteric recurrence without systemic recurrence or diffuse peritoneal recurrence is a very rare event in terms of cause of death. Also, in all of our practices, we certainly know that there is significant variation with respect to lymph node count. Variation at the level of pathologists. You get different number of nodes with different pathologists, but also variation at the level of the patient. So even when you do the same operation, you have the same pathologist who's good at finding nodes, you'll find some people have very few nodes and some people have a lot of nodes. So there's obviously a really important patient level factor here. But that's not to say that the number of nodes can't be improved, and there are some areas where we definitely can do better. This is a study in Ontario which looked at 2005 data by region in terms of the proportion of colon cancer patients who had at least 12 nodes identified. And you see the median is, for all the regions, is about 69, 70% or so. But there are definitely some outliers, and this is one region that had 32% of patients have 12 or more lymph nodes evaluated. This information was fed back to this unit, and in fact what we see now is that this unit's gone to the best performer, so having 94% of individuals having 12 or more lymph nodes identified. So clearly we can improve our practices, and I'm not saying that we should accept low lymph node counts in general. But just improving our lymph node evaluation is not necessarily going to improve patient outcomes, and I think we have to be very realistic about that, because better staging and better treatment really do not explain much of the survival improvement seen with more lymph nodes, that association. Some of it is certainly stage migration, why you see better outcomes with more lymph nodes, but tumor-host interaction is also probably very important in terms of this relationship. There are actually some researchers in France that have been actively looking at this, and what they're looking at is the immune response of the host to the tumor, and they're measuring this by the number of and type of immunologic cells within the tumor, the host response to that tumor. And what they found is by looking at this, they're able to predict prognosis for these patients better than traditional staging. So there's likely something related to tumor-host interaction, something that we may be able to harness for treatment. Well, many people say to me, yeah, Nancy, we've heard you talk about this, we've heard you get on your soapbox, but really what's the downside of increasing the number of lymph nodes and using it as a quality marker? Well, I think that what we're doing here is we're focusing quality improvement in an area that's really unlikely to result in patient benefit, and I have an inherent problem with that. Having said that, rapid improvements may engage clinicians, so if you're able to institute a quality improvement project and you start with this, you may get buy-in because you've been successful. And it may be very useful if you're in that particular region that had only 32% of your lymph nodes, of your patients have 12 or more lymph nodes. So I think if you have a very low lymph node count on average, you do need to improve, and it's probably fairly easy to improve. But I think there's also some potential to harm to clinicians in terms of things like reputation, financial, and litigation. What happens if a patient recurs and they had less than 12 nodes identified? Are you liable to be sued? And again, I also think that what we're doing is we're failing to recognize that identifying 12 lymph nodes, or how many lymph nodes you identify, may well be an independent prognostic factor, and perhaps treatment should be based on the number of lymph nodes identified as one of the factors that we decide on adjuvant therapy for. And I think it's important to think about what we're doing and why we're using this, because this is how it's currently being used. This is some data from the National Cancer Database, which looked at all the hospitals in their, within their database and gave a report card saying how many individual hospitals met this 12-node benchmark, and saying that more than 60% of institutions failed to achieve this benchmark and needed to improve their practice. Well, I must say that I don't think 60% of institutions in the United States are giving poor quality care for colon cancer. I just don't believe that. So in summary, staging for colon cancer is important, and node evaluation in the past has been inadequate. So I think if you're routinely getting 5 nodes, 6 nodes in your specimens, that's inadequate. You have to have a look at what you're doing and a talk with your pathologist. I think the number of nodes evaluated reflects a very complex interplay between patient, tumor, surgeon, and pathologist, and being very dogmatic about it just being a pathologist problem or just being a surgeon problem is failing to understand this issue. Again, if you routinely find few nodes, you likely are understaging patients, and that's a problem, but it's a problem that's solvable. This relationship, though, between node number and survival is not a causative association. I think that's something to keep in mind, because just finding more lymph nodes, unless you routinely find very few, will not improve outcome overall or for any given patient. Thank you.